Hi class, this is Mary Hutchison from the ECPI University NUR321 Pathophysiology class in the BSN program. Today I'm going to give you a presentation about a pathophysiology case study on a patient that was diagnosed with acute kidney injury. This patient is identified as BB. She's a 68-year-old African-American female. She presented to the emergency department with complaints of severe abdominal and back pain. Her initial diagnosis in the emergency department was for hypertensive crisis due to her blood pressure of 201/151. From there, she was admitted to the acute care unit. And in the acute care unit, she was finally diagnosed with an acute kidney injury related to a Bactrim regimen that she had been taking for a recent urinary tract infection. Her past medical history: she has coronary artery disease, for which she had a coronary artery bypass graft surgical procedure. She has hypertension. In the emergency department, they believe that her hypertensive crisis was due to noncompliance with her hypertension medications. She also has stage 4 chronic kidney disease, which plays a big part in this case study. And she also has type 2 diabetes mellitus. So she was taking Bactrim. She had finished the Bactrim regimen 3 days prior to this emergency department visit. She had completed the whole course of it that she was taking for a urinary tract infection. So the thing about Bactrim is it's eliminated through the kidneys. The way it's eliminated, it binds to plasma proteins, and then these plasma proteins are eliminated. It travels through the body and is eliminated through the kidneys. The problem for BB is she is in stage 4 chronic kidney disease already. So her kidneys were unable to remove those proteins that the Bactrim has been bound to. And Bactrim actually comes with a contraindication for patients that have renal insufficiency to not take this medication unless their renal functions are being closely monitored, which she was not. So because her body was unable to excrete the medication properly, she now had toxic levels of this medication circulating through her body, and that further caused this acute kidney injury. So the effects that this acute kidney injury had on her body was a total loss of her kidney function. She was already at a pretty significant loss of kidney function, but the Bactrim put her into a complete loss. This complete loss of kidney function caused further buildup of toxins from the medication circulating, as well as metabolic waste products, which we'll get into further in the laboratory section. And then she also already has hypertension, but her body, those kidneys were not able to control her blood pressure because they're not able to produce the renin needed to control blood pressure. And so she went into hypertensive crisis. And then also with the kidneys not functioning, she had an inability to regulate her fluid and electrolyte balance, which was shown most expressively with her labs showing her in hyperkalemia. So these are results of the diagnostic blood tests that were done. These are tests that are part of the renal panel to show how well your kidneys are functioning or not functioning. So from this serum BUN, which is blood urea nitrogen, this is a metabolic waste product from the breakdown of protein in the body. So normally this is something, the urea nitrogen would be eliminated through the kidneys through urine, but when you check for serum blood urea nitrogen levels, this is the urea that is unable to be excreted, and it's circulating through the bloodstream. So a normal for a female, African-American female of her age of 68 years old, a normal range for BUN would be 8 to 21 milligrams per deciliter. And BB's was 47. So she has very high level of urea, this urea nitrogen waste product floating around in her, circulating around in her blood. Another significant test for kidney function is your serum creatinine, which is also another metabolic waste product of protein. And a normal for her age and range, her age, sex, and race is 0.51 to 1.1 milligrams per deciliter, and BB's was a 3.6. So this is just another example how toxic these metabolic waste levels were in her blood. And another test that they do to measure kidney function in the renal panel is called EGFR, which is your estimated glomerular filtration rate. And this is done through a formula devised by the laboratory or physician based on age, race. So for BB, for her being a 68-year-old African-American female, her normal glomerular filtration rate is at 85. That would be the expected normal for optimal functioning kidneys. In this case, so this just is a rate of how well the glomerulus in your kidneys are functioning. And so for her, she had a 16. And you can see on this for end-stage renal disease, which is complete kidney failure, is a 15. So she was right on the border of complete end-stage renal failure. And then the other key blood test that was done for BB was her serum potassium. So potassium is also a significant test on kidney function because kidneys also regulate your fluid and electrolyte levels. And so potassium has such a very narrow range, and if it's not excreted, it can cause a lot of issues in the body, namely cardiovascular. So the normal serum potassium range for somebody of BB's age is a 3.5 to 5.3 milliequivalents per liter. BB's blood test came back for potassium of 6.9. And as you can see, a critical level of potassium is above a 6. So she was definitely in a severe state. Some other diagnostic procedures that were done were some radiology. She had an echocardiogram, and the results of that were just significant with her history of coronary artery disease. She has some severe left ventricular dysfunction as well as mitral valve stenosis, regurgitation. She had an ejection fraction of 50 to 55%, which shows, how much blood is actually pumping out of that heart. And so a normal is 55 to 70%. So she was a little bit degraded from normal as far as her circulatory function from her heart. She also had an electrocardiogram or ECG, and this showed that she was in sinus bradycardia. She also had elevated T waves, and she also had random premature ventricular contractions. And those are also, that elevated T waves is also a sign of a severe hyperkalemia. And this hyperkalemia, at the level it was, you saw the normal is a 6. She was at a 6.9. She had a severe cardiac arrest potential. She was right on the verge of probably cardiac arrest. And with the prevalence of the PVCs as well, showing that. She also had an abdominal CT scan, And this scan showed that she had significant bladder distension, the urinary bladder, as well as severe calcific arteriosclerotic disease. So the arteries in her abdomen, namely, feeding the kidneys, were calcified, which is significant with the hypertension, with the stage 4 kidney disease as well as causes of this. And those all coincide with what she presented with her symptoms. So her treatments for acute kidney injury, we had a hyperkalemic protocol through the hospital. And with this protocol, we started an IV piggyback bag of calcium gluconate, which was 1,000 milligrams per 100 milliliters. And that calcium, what it does is it helps combat excitability of the heart. Then we also gave an IV push of D50W, which was a glucose, 25 grams and 50 milliliters. We pushed that through IV over 5 minutes per hospital protocol. And what this does is it sets the patient up to keep from going into hypoglycemia event when we next push the insulin. And so after the D50W, we pushed the 10 units of regular insulin. And what that insulin does is it helps push the potassium back into cells out of the plasma, so it can be utilized and excreted. And then follow that up with another IV push of sodium bicarbonate, 50 milliequivalents per 50 milliliters. And that was pushed as well over 5 minutes. And that sodium bicarbonate also further pushes that potassium into the cells and out of the plasma. And then finally, we gave a Veltassa, which is also patiromer, which you could also give K-Exolate, works the same way. It's just a powder that's mixed in water that she drank. And so what that does is it binds to potassium that's in the GI tract, and it instigates bowel movement to excrete the potassium through defecation. And then after this protocol, so 30 minutes from when we administer the insulin, per hospital protocol, we were to recheck her potassium. And at that time, 30 minutes later, her potassium levels came back as a 5.2 milliequivalents, which is within normal range. So she went from a above critical 6.9 down to a 5.2 within a matter of 45 minutes for the total protocol. And so that dropped her potassium pretty significantly. And also from that protocol, she was experiencing some chest tightness, some chest pain because her potassium had dropped so quickly. So we just stayed monitoring her. We monitored her telemetry and as well as her, watching her symptoms, keeping an eye on her back and forth between her and telemetry to make sure that she was not going to go into any cardiac arrest. She originally was showing PVCs again, along with the chest tightness and some just irregular heart rates going on. We stayed with her, kept an eye on the telemetry again, as I said, and probably within, I would say, 15 to 20 minutes, maybe 30 minutes overall, her heart rate had gone back into normal sinus rhythm. She was no longer experiencing any chest pains or tightness, and she overall felt better. So her prognosis expected with her having this acute kidney injury with her age and everything. It's a very high mortality rate, especially with her above critical hyperkalemia. So then when you add acute kidney injury with a stage 4 chronic kidney disease, coronary artery disease, her hypertension, her type 2 diabetes, and the fact that she was 68 years old, considered elderly, with all that together, just severely increased her mortality rate. So her prognosis, with a strict adherence to anti-hypertension meds and an immediate hemodialysis routine, she could live possibly 1 to 2 more years. And this prognosis comes from a teleconference that she had shortly after, maybe a couple hours after we got her potassium under control. We did a teleconference with a nephrologist, and this was his prognosis. He also determined that the acute kidney injury is what was a product of her taking the Bactrim, and these are the prognosis that he came up with. So a strict adherence to her anti-hypertension meds, that came out in the teleconference that she really was not keeping up with her hypertension meds as she was supposed to, because she was on so many different ones, and she really had a hard time figuring out which ones to take when. And so that was adding to her problems as well. And then the nephrologist also said that, with her stage 4, if she didn't start hemodialysis immediately, as soon as she was stable, released from the hospital, that she wouldn't live much longer. So he said if she stuck to her antihypertensive meds and got started a hemodialysis routine immediately, that she could possibly extend her kidney function 1 to 2 years and extend her life for that. So our nursing care and education, because she had a hard time, she expressed how she had such a hard time keeping up with her medications, and that was why she was non-compliant. We created a calendar for her. We went through her whole MedRec and created a calendar for her of what to take, when to take, what she's taking it for, all at her requests, what to have on there. Because she lived by herself, she didn't have anybody that could help her keep up with her medications. So we also talked with the case manager about that as well. And so the case manager got on board with helping arrange some home health for her to help ensure that she keeps up with her medications, and also to provide her transportation to dialysis. She didn't have anybody or any transportation that could ensure that she could get to hemodialysis on a regular basis. We also got a consult for her with the hospital nutritionist to help her understand and learn what diet she should have that would be helpful for her heart, her hypertension, and her kidney function. And then she also had that nephrologist consult, and also is being consulted with a cardiologist. So this interdisciplinary care team put together to help her be successful. So in conclusion, this was about a patient named Vivi who came to the emergency department just with complaints of abdominal pain and back pain. And turns out she was in acute kidney injury. She nearly was about to have cardiac arrest. And it was all from her taking Bactrim, the antibiotic, on top of her pre-existing stage 4 chronic kidney disease. And so with the rapid treatment that we did for that, with that hypokalemic protocol and strict monitoring her, she was able to come back within normal minutes and resume kidney function to a level which she was prior to this. So with strict medication adherence, hemodialysis, and a good heart healthy, kidney healthy diet, then she would be expected to continue to improve and hopefully get about 1 to 2 years improved life expectancy, as the doctor stated. So this is the end of my presentation. Thank you for listening, and I hope that you enjoyed it, and I hope that y'all learned something from it as well as I did. And if you have any questions, please feel free to put your questions in the comments below on my YouTube channel. Thank you.